Hello, today we're going to be talking about disorders in childhood and adolescence. As you may already be aware, some disorders are unique to this period of time, whereas other disorders are shared um, by adults and children and adolescents. Sometimes when a child or adolescent experiences one of the same disorders that occurs in adulthood, the disorder may manifest itself differently because of developmental differences in things like cognitive development between children and adolescents than adolescents and adults. A good example of this would be problems with anxiety and also depression that show more physical symptoms in children than even in adolescents and adults, because in part children lack the cognitive skills to be able to experience and express their symptoms in non-physical ways. Because of this developmental difference, sometimes psychological disorders may get overlooked in young people. As far as anxiety is concerned, one anxiety disorder that's more unique to childhood is separation anxiety disorder. As you're probably aware, separation anxiety is a normal experience that children tend to go through towards the end of the first year of their life and into the second year of their life, but they tend to outgrow it. However, there are some children who continue to have significant problems with separation anxiety disorder well into childhood and some even into adolescence. Sometimes this disorder may take the form of school avoidance. Fortunately, there are some effective treatment approaches that have been developed to help kids with separation anxiety disorder that involve working with the parents, and in the case of school avoidance, with the parents and the teachers together to help the child to overcome this kind of anxiety difficulty. One of the dynamics that's sometimes present in separation anxiety disorder is that a member of the family, typically a parent, has undergone a significant illness, or perhaps a parent has even died, and the child is afraid that something bad may happen to someone in their family when they are separated from them. One interesting disorder that tends to occur in childhood, or really it's two different disorders that we might talk about that kind of go together in a sense, that are disruptive kind of behavior problems that children might have. One is called oppositional defiant disorder, and the other is called conduct disorder. You would want to know the difference between these two disorders. They could be easy to confuse because there's a little bit of overlap between them, but they also have some distinctive features. In the case of oppositional defiant disorder, what you find is children who are extremely resistant to adult authority and will sometimes have extreme reactions when an attempt is made to set limits with them and when they don't get their own way. They tend to become overtly defiant, sometimes even to the point of having temper tantrums when they aren't able to be successful at getting adults in their life to allow them to do what they want to do. Conduct disorder is a more severe kind of disorder in children where the child will engage in behavior that violates the rights of other people. You don't tend to see that so much in oppositional defiant disorder, but in conduct disorder, it's one of the main symptoms. So in conduct disorder, children will sometimes become aggressive They may become not only physically but sexually aggressive. They may destroy property, start fires, harm animals. Rather serious behaviors that can begin to emerge fairly early in life and sadly oftentimes become worse over time. In fact, when these children become adults, many of them develop antisocial personality disorder. And in fact, when you look at the criteria for the diagnosis of antisocial personality disorder, one of them involves the presence of symptoms of conduct disorder, prior to the age of 18. Another category of disorders in childhood that we might talk about a little bit today are the neurodevelopmental disorders. These disorders include attention deficit hyperactivity disorder, autism spectrum disorder, and also intellectual disability. Attention deficit hyperactivity disorder, as you may be well aware, is a diagnosis that is typically made in childhood, but some of these children end up continuing to have symptoms of ADHD in adolescence and even into adulthood. The diagnosis is made more often in boys than in girls, and the disorder can manifest itself in different ways. Some children tend to have primarily hyperactive impulsive symptoms. Other children tend to have primarily inattentive symptoms. And then there is a third group that has a combination of both hyperactive impulsive and inattentive symptoms. There is a fair amount of controversy surrounding ADHD regarding both its diagnosis and treatment. But many people in the field would say that probably the optimal approach to the treatment of ADHD involves a combination of both behavioral therapy and medication. So researchers have tried to figure out what might be going on in the brain of children with ADHD, and one of the things they found is that that the frontal lobes of the brain of children with ADHD seem to be underactive. As you're probably aware, the frontal lobes are important in self-regulation. That is, they help us to be able to put the brakes on our behavior, to be able to stop and think about consequences before we act. And the frontal lobes are also important in helping us to focus our attention. Well, the thinking is that this area of the brain may be underactive in children with ADHD, possibly because of underactivity of the neurotransmitter dopamine in this area of the brain. So medications that are used to treat ADHD, psychostimulant medications like say Ritalin, will help to increase dopamine activity in the frontal lobes of the brain. And this in turn helps that area of the brain to function more normally, which in turn helps the child to have better self-control. Sometimes parents really aren't interested in anything more than placing their child on medication for ADHD, which is unfortunate because researchers have found and clinicians have found that when you combine a psychological approach to treatment with medication, it helps parents and teachers to respond to the child in a more positive and consistent way. And it also helps the child to be able to learn better coping skills, including better self-regulation skills, so that they become better equipped to manage their symptoms themselves. Another of the neurobehavioral developmental disorders is autism spectrum disorder. In DSM-4, it was referred to as autism, and then Asperger's disorder was also in DSM-4 as well. But in DSM-5, they combined them into what is now known as autism spectrum disorder. In high-functioning individuals who used to be characterized as Asperger's might also be given a different diagnosis in DSM-5 having to do with a communication disorder. I believe in DSM-5 that particular kind of disorder is referred to as social communication disorder. So, as you may be aware, autism spectrum disorder can be a disabling disorder, one that has lifelong implications. And individuals diagnosed with autism spectrum disorder can show problems in 3 areas: lack of responsiveness and social reciprocity, where they have great difficulty relating to other people; communication problems, where it's hard for them to develop language for the purpose of communication with other people; and they might also show highly rigid or repetitive patterns of behavior. Of course, it's a matter of degree because the disorder affects along a spectrum from mild to severe. I've known a number of individuals functioning at the higher end of the autism spectrum disorder continuum, and oftentimes they function fairly well in the world, but they do have difficulties relating to other people and kind of managing their emotions. They have some really fascinating qualities associated with the disorder. Most of the individuals I've known have been children and teenagers functioning at the higher end of the spectrum in what used to be called Asperger's disorder. And one of the things that you'll find with some of these children is that they have a highly developed interest in one area. Like, I knew a young man once who knew about all there was to know about car washes. He'd really become quite an expert on car washes. He subscribed to a car wash magazine, and he and his father had visited many car washes, and he could tell you an awful lot about how car washes work. I knew another young man who was diagnosed with Asperger's disorder, what would be now either social communication disorder at the higher end of the autism spectrum, who was very intrusive. And with his mother, when she would have conversations with her friends, he would just want to be right in the middle of it all the time. It would sometimes blurt out comments that were socially inappropriate. But both of those individuals were able to learn how to improve their social skills and gain better understanding of and regulation of their emotions as a part of their therapy. But those functioning at the lower end of the spectrum, especially if they have low IQ and if they're not able to develop language for the purpose of communication with others, have a much harder time of it and require a lot more assistance from others throughout their lives. There are various ideas about what might cause autism spectrum disorder, and some of these are explored in your book. Back in, say, the 1950s, the parents were blamed for autism. and a term called refrigerator parents was used to describe the kind of parent who might produce an autistic child. That is, a parent who would be cold and emotionally aloof. Researchers now know that this is not a cause of autism, and the person who came up with that idea later apologized for it, realizing it was really very unfair to characterize the parents in that way and put the burden on them. The more promising evidence points to probable brain abnormalities and genetic factors that are associated with autism, but no one has really yet identified a common pathway. There are just various possibilities that have been explored, like structural abnormalities in the brain, for example, and genetic factors where if you're an identical twin and you're autistic, there's about a 60% chance that your twin would be autistic as well. Complications prenatally and at the time of birth may also be associated with autism, including exposure to viruses like rubella. But autism is a complex disorder, varying greatly in severity, and one which involves, by necessity, really a team of people who work together to help individuals who are experiencing this particular disorder. Well, something else that's interesting that you sometimes see in individuals with autism, a communication problem that they have, is something that's called echolalia, where they repeat back to you what they hear you say to them. And they may also show what's called pronomial reversal, where they will speak about themselves in the third person, where you may say, "How are you doing today?" And they may say, "Billy is doing fine," or "he feels fine," if they're able to communicate at that level, where they're really talking about themselves in the third person. The third category of neurodevelopmental disorders is intellectual disability, which previously was referred to as mental retardation. And as you're probably aware, a diagnosis of intellectual disability is made in part based on a person's tested IQ score. So IQ scores below 70 are in the range for intellectual disability. There are various factors that have been identified that are associated with intellectual disability, including genetic factors, prenatal environmental factors, and postnatal environmental factors. You may be well aware of two genetic chromosomal abnormalities that are associated with intellectual disability, namely Down syndrome, also called trisomy 21, and Fragile X syndrome as well. Finally, I did want to mention the diagnosis of disruptive mood dysregulation disorder, one of the mood disorders, and a diagnosis that is typically made in childhood or adolescence. As you may be aware, this diagnosis was added to DSM-5 because of concern about the overdiagnosis of bipolar disorder in young people prior to DSM-5. The developers of DSM-5 reasoned that because of this concern about overdiagnosis, perhaps if an alternative to that diagnosis were developed, it might provide a means for which children who show some of the behaviors that were upon which a diagnosis of bipolar disorder was based, but perhaps didn't really indicate the presence of bipolar disorder, could be viewed in a different way with this new diagnosis of disruptive mood dysregulation disorder. So what you tend to find in these children is, yes, they do have extremes of mood, oftentimes manifested in severe outbursts of anger, but perhaps not yet indicative that they have bipolar disorder. So this diagnosis would be made initially during childhood, and if severe problems with mood extremes continued into adulthood, then the diagnosis of bipolar disorder might be made at that time. Well, that's about it for now. I'll look forward to talking with you again soon. Thank you.